Right, thank you. Right. So cervical spondylotic myelopathy. Let's define it. I like to define I would like to define it like functional deficit resulting from compression of the spinal cord, like short and simple definition. So what's the etiology? What is causing cervical spondylotic myelopathy? This could be stenosis, this could be instability, trauma, or post-traumatic deformity. So we have usually a course that is chronically progressive, or subacute or acute course of the disease. And the major cause of the disease is cervical spondylosis. Usually we have prevalence of males over females, and usually it's old age, although we have some cases in young age as well. So let's say something about the history, because we have to respect the teachers. So Victor Horsley, for the first time, performed an operation for cervical spondylotic myelopathy as early as 1892. He did C6 laminectomy for a patient with progressive paraplegia, and he had a complete recovery over a year, because he had performed this operation on early stages. So this is let's say something about the pathogenesis of the cervical spondylotic myelopathy. You have a static factor, which will be the compression of the spinal cord. As you can see here, the disc is collapsed, and this is causing buckling of the ligaments. This is causing hypertrophy of the facets, and this is causing the spinal cord to be badly squeezed. And this is the static factor in the pathogenesis of the cervical spondylotic myelopathy. In 2% of the cases, you have congenitally narrow canal, but in the rest of 98%, it is degenerative. So the degenerative cascade we have already mentioned before. This will be disc degeneration because of the dehydration, and then spondylosis of the adjacent structures, and then you will have narrow canal, and then you will have problems with the spinal cord. Apart from the static factor, we have dynamic factor. So in case you have instability, you will have repetitive trauma of the spinal cord during the everyday movements. And like that, you will have another moment that will impair your spinal cord. And this is a good drawings that demonstrate how the spinal cord is being injured because of the instability. If you have instability, you will have osteophytes, you will have stretching of the spinal cord. Over the osteophyte, you will have buckling of the yellow ligament, and you will have repetitive trauma of the spinal cord on everyday movements, and the spinal cord will suffer and will get myelomalacia, and then the patient will be myelopathic. Right. So all this is resulting in a vascular problems, and this is namely venous congestion and also direct compression of the arteries. And because the spinal cord is very sensitive to ischemic, the spinal cord has very low ischemic tolerance, and it will start degenerating, and the patient will become symptomatic. So there is, nowadays it's very modern to put CSF in everything. So we have also CSF contribution, slow metabolite elimination. I was talking about that yesterday for brain. Many people see that also in spinal cord, slow metabolite elimination, cord edema, and Cyrex formation. That's something that we know. So what the neuropathologists see in the myelopathic patients, you will see degenerated central gray matter at the stenotic level. Interestingly, you will see posterior funiculus degeneration above the stenotic level, and you will see lateral funiculus demyelination below the level. So anterior funiculus is normally spared until very late stages. So the clinical expression, we have slowly but progressive course. The course is usually progressive, and that's why it is worth it to be caught on early stages. In case we have to do something, it is worth it to do on early stages, because what is taken by the disease usually is not coming back. So your patient will complain normally of gait disturbance. You will see a spastic gait, you will see balance problems. The patient will have frequent falls in the late stages. The patient will complain of dysesthesia of hands and foot. He will have impaired dexterity of the upper limbs. Women usually say, when I cook, I drop things. I cannot manipulate fine objects. Men will say, I cannot do my laces, I cannot do my buttons. These are the most common problems that the patient will have, and that will bring the patients to you. You can see weakness of the small hand muscles, biceps, triceps as well. There is a good prevalence of bowel and bladder disturbance as well, and there will be radicular symptoms. There is good research suggesting that if myelopathy is combined, if you see radicular symptoms together with myelopathy, then usually this is a progressive condition, and you may need to treat that early. So the usual examination, you will do neurological examination. You will see upper motor neuron signs. You can see upgoing tendon reflexes. You can see polyclonal answers. You could see pathological reflexes, namely Hoffmann-Babinski, muscle atrophy. You could see Lermit sign. You could see radiculopathy. Grading of the myelopathy, there are many scales now, but classics is Neuric score that is designed by Neuric in '72. You have 5 grades, while grade 5 is chair-bound or bedridden. Grade 0 is nerve root signs and symptoms, and no evidence of spinal cord involvement. Normally, I can follow the patient in that grade, but as the patient is entering this grade, I normally am a bit more active, and I tend to operate on early stages, because what is taken by the disease is not coming back usually. So another score is like Japanese Orthopedic Association score, 0 to 17 points, and here, unlike the Neuric, you need to get more points. So patient is good when it's close to 70, but not close to 0. Neuric was close to 0. This is close to 70. History diagnosis is normally established with history, examination, MRI standards. You will see spinal stenosis there. You will see signal changes of the cord. There is usually no direct clinical correlation, but if you see high T2 signal changes, and especially T1 signal changes, this is worse prognosis. This was mentioned already. If you see T1 signal changes, usually the patient will not recover after the surgery, or will recover minimally. But if you see high T2 but no T1 changes, the patient may recover after that. Usually I consent my patients saying that you will not recover. Probably we are doing the surgery for you to stay as you are, and this will be silver medal, but you may get gold, and I promise more gold medals in case I don't see T1. So let's speak about the MRI findings. You could say that you have relative stenosis if your AP diameter is millimeters, but if it's below 10, you have absolute stenosis. And there is a correlation of the stenosis and the clinical expression of the disease. If you have over 30% reduction of the AP diameter, or if you have the reduction of the area of the cross section less than 50-60 square millimeters, then you have a symptomatic patient usually. This is established by these people here. So usually I support my diagnosis with flexion extension X-rays. Sometimes if I'm uncertain, I could do also CT scan. On the CT scan, you will see if your disc is calcified, or you could see the foramina. You could see how much laterally you should go. Nowadays, the MRI scans, they could provide also oblique views, so you could replace the foramina views of the CT scans with that. Ultrasound for bladder test to see how much we have post-voiding. Sometimes you could consider cranial MRI scan as well. I have a few patients that I found NPH together with a narrow neck as well. Electrophysiology is helping. You have to consider SSAP and MAPs, and there is a good clinical correlation with progression of the disease. In case you're having a reduction of SSAPs and MAPs, then the disease is progressing, so you have to act. If you want to do a differential, you could consider AML of follicular myelitis. You have to check your B12. You could send serology for borreliosis. You could have polyradiculitis, and you could have syringomyelia. This also could be considered in the differential. So what is the natural course of the disease? About 70% of the patients that are myelopathic will progress, and 1/3 of the progressing ones will have stepwise progression, and 2/3 will have continuous progression. MRI progression over 10 years is about 80%, so you will see worsening on the MRI scan. Predominantly old age. If you have the asymptomatic radiologic compression will progress with a rate of 5% per year. And clinical deterioration could be also rapid. And if it's progressing, usually rapidly, you will have no recovery of the symptoms. So if you see that, you have to act fast. So that's my approach. If I have these scores, I could treat my patient conservatively, or if the patient is very slowly progressing, or stable, I could observe. If it's very old, I could observe, or if it's very poor prognosis, namely long-lasting gait problems, significant muscle atrophy, if the patient is already paraplegic, if we don't have this, when we do a neurophysiology, I might consider just to do conservative treatment. What is conservative treatment? You may consider rest. You may consider color. Actually, I put a lot of my patients which are having radiculopathy in color first, soft color, to see if that will improve their symptoms. You may consider physiotherapy. Some people will do traction and they report improvement, like temporary improvement in up to 81%. I haven't done that. Epidural steroid injections, I haven't done that for myelopathy, but people are doing it. So surgical treatment, we mentioned already that in case it's progressing, if you see para or quadriparesis that is progressing, that's an emergency. You have to act on that. Elective patients are normally operated with Japanese orthopedic score 8 to 14 or Nuric 1 and less, or failure of the conservative treatment, or sometimes intractable pain due to radiculopathy. Surgical goals are normally to avoid progression. That's goal number one. Usually that's what we say to the patient. We are operating you to keep you as you are. And I don't normally promise recovery of the symptoms. We have to decompress. We have to decompress the cord and the nerves. We have to fuse. More motion preservation I don't know. So usually these are old patients, and there is no point to use motion preservation devices. Some people consider. So when you have to decide how you would treat your patients, you have to consider some basic biomechanical facts. So usually the cervical spine is the most mobile spinal segment. You have cervical lordosis that is about 14 degrees. The weight-bearing axis is posterior to the vertebral bodies, unlike in thoracic and lumbar. Load transmission is mostly in the posterior column. And if you change the angles in one motion segment, usually the adjacent segments are reflecting the change, and sometimes there is also a global change of the angles and then global balance change. So you have to be careful with these things, and you have to consider the biomechanics. So sometimes we cause problems with the balance, with the sagittal balance. So I put here also pathological conditions, but also iatrogenic. That's why, again, I'm stressing on biomechanical importance of biomechanical considerations, and also trying to keep the normal angles. Try to not to fix as it is, but try to restore angles in case possible. Otherwise, you will start the vicious circle and the patient will get worse. So decision making, it's usually, that's the first question that we have to ask ourselves if we see a myelopathic patient, to operate or not to operate. And we have to consider many factors. Let's say this one, 63-year-old teacher, still at work, neurologically intact, neck pain. But you can see here that is very, very tight. Would you operate that? Anybody would operate? Anybody would not? Who will operate that? Okay.
Neck pain only?
Just that. Just that.
Yeah, I wouldn't.
You wouldn't, yeah? I have done a serial of electrophysiology for this patient, and it's stable. So I'm still following up without operation.
Right. So that if you look statistically at operating on asymptomatic cervical stenosis without myelopathy, the risk of surgery actually exceeds the risk of someone deteriorating suddenly.
Exactly. That's what I have explained to this patient, and he is not really keen to have an operation. And he understands, he's an educated man. He understands all these risks and benefits from everything. So I'm still observing this man because he's still fine. And then this is the data. If you want to read this article, it says that you could use the EMG as a predictor, and this is class 1 evidence. So then, next case, 39-year-old farmer's wife, neck pain, radicular pain, dexterity decline, Hoffman signs positive. Who would operate that? Okay, right. So this is the data suggesting that if you have myelopathy and if you have radicular symptoms, then your problems are likely to progress. So it is advisable to operate on early stages. So you will prevent patient from becoming handicapped in the long term, and you will preserve the functioning of the patient. It's a young patient, and usually I'm very active in that case. So do I have still more time, or should I continue?
Should wind up.
Okay, well, the rest is what we can do and back and forth and all this, but that's not the scope of the talk. Probably somebody else will talk about that. So thank you.